have a 70-year-old female in the ED with syncopal episode while walking, preceded by chest pains. How do I go back to that? Yeah. Oh, there you go. Preceded by chest pain and shortness of breath. These are her vital signs. Physical exam is notable for cardiac murmur radiating to the thorax. What is the diagnosis? Aortic stenosis. So the classical signs are syncope, chest pain, and shortness of breath.
Nice.
That's already solid.
So what interventions should be avoided in patients with aortic stenosis? Nitroglycerin. So aortic stenosis is volume dependent, so you don't want to give any medications that would decrease the volume. So nitroglycerin is okay. Allergies still in the lead. Which of the following is not commonly associated with aortic stenosis? Endocarditis. So atrial fibrillation, CHF, and pulmonary edema are all common complications of aortic stenosis.
Yeah. Just endocarditis would usually give you a regurg murmur, wouldn't give you a stenotic murmur.
The next couple of questions are more on the easier side, but I wanted to include them because they're kind of really easy points, and there was a surprisingly large number of questions on these things in the question bank. So it'd be just good points. So 28-year-old, no significant past medical history, coming with syncope. This is his EKG. What is the pathophysiology of his condition? Close. So the correct answer is sodium channelopathy. The EKG was Brugada syndrome. You have that like saddleback type ST segment, which is common for Brugada syndrome, which is a sodium channelopathy.
You could show media.
Can you show that EKG again?
So there you have in V1 and V2, you have that like saddleback.
The biphasic ST.
Yeah.
ST. The saddleback is type 2. This is type 1.
45-year-old female with no past medical history coming to the ED with palpitation. She's afebrile, her heart rate's 215, she's hypertensive. This is her EKG. What is the best next step? Good, so sedation and synchronized cardioversion because it's unstable SVT. 47-year-old male presents with chest discomfort followed by syncope. Review systems otherwise negative. What is the most likely etiology? This is the EKG. So we have the classic delta wave, we have the prolonged QRS complex, and the short PR. What is the recommended therapy for patients with syncope due to WPW syndrome? Preventative therapy is catheter ablation. 67-year-old male with coronary artery disease and CHF coming in with 3 days of palpitations and fatigue. This is the EKG that you see. What is the diagnosis? Atrial flutter, so you have the classic sawtooth pattern.
And whenever you have a tachydysrhythmia around 140, 150, that's very regular, you want to think of a flutter as one of your differentials with 2-to-1 block, a flutter with 2-to-1.
72-year-old female with hypertension, coronary artery disease comes to AD with 2 weeks of weakness and shortness of breath. Her blood pressure is 100/60, heart rate is 38. This is the EKG. What is the next best step? Consult cardiology for pacemaker replacement. This is a 3rd-degree AV block. You have no relation between the two.
I know this is a pre-made question, but that's not really the answer because we don't call cardiology, we just do it ourselves.
That is the answer.
That's the better answer, but it's not up there.
And
In other institutions, you would.
Yeah, in lesser institutions, that's the correct answer.
and until cardiology gets there, or until you get there and you get in that pacer, you have some alternatives, right? One is that you can try atropine, which won't work for this, but then what you can do is you can, to buy time, you can either put on an external pacemaker, right? That may work, or if that doesn't work, while you're still trying to get inside the pacer, the internal pacer, you can hang either a dopamine or epinephrine drip to support the heart rate.
Thank you. So 84-year-old male with prior MI in the ED with lightheadedness. Blood pressure is 90/50, heart rate of 165, respiratory rate 20, and afibrotic. This is the EKG. What is the most appropriate treatment? So the correct answer is cardioversion, but kind of like I was at first, a lot of people are going between cardioversion and defibrillation. So because this patient has a pulse, it's appropriate to cardiovert. If the patient did not have a pulse, then the appropriate answer would be defibrillation.
I know that wide complex almost around, I don't know if the machine will sync on that.
It will, that one's
organized.
It's not like a corsage or a main, not, but that it will.
Yes, Robbie?
If it is monomorphic feedback, ACLS does say you can use adenosine, right? And there's a paper published by people in this room saying that's safe and effective.
Yeah, I think we were just talking about this week, dedication downstate. It usually works in like only 5-10%, but it is a good first line. If you can get it done quick, if you have to wait, then you should go to electricity.
Plus, I think the point of this is, I think they're just trying to say it's the patient unstable, right?
Yeah, with 90/50 pressure.
And dizzy and remember, whenever you have an unstable tachydysrhythmia, you want to, especially on the test, synchronized cardioversion is the treatment for an unstable tachydysrhythmia. That's so fast that they're becoming unstable, they're becoming hypotensive.
So 73-year-old male with hypertension and COPD coming in with chest pain. Who's doing this on the lung problem, and you see different types of P waves.
Can you show that again, just for a second?
I'm not sure, but how do we go back?
Nope.
No, sorry.
Right.
I'll send it out with the.
Yeah, we're gonna
after.
send it out. But MAT, what you see is they have a tachydysrhythmia, and they have, in one lead, they have more than 3 types of PAC, 3 or more, different
Pathology.
ways.
So you had this 50-year-old with chest pain. The EKG does show type 1 second degree AV block. You see the PR segment getting longer, and then you have a drop in the beat. So you have a 72-year-old male with diabetes coming in with chest pain for 4 hours with nausea and a pediatric discomfort. He has some ST elevations in 2 degree anemia. He's given nitroglycerin and he becomes lightheaded, nauseous, and weak and hypotensive. And now has diaphoresis, low extremities, and otherwise normal exam. So good. So you optimize preload. So this patient is now, he initially had a STEMI. You gave him inferior wall STEMI. You gave him nitroglycerin, which is not a great thing to do in inferior wall STEMIs because they're preload dependent. So then essentially he went into cardiogenic shock. So you want to try to optimize preload. And then eventually you want to try to get thrombolytic therapy because he does have a STEMI, but while you're doing that, you should optimize his blood pressure.
Whenever you have an inferior wall MI, that's 2, 3, and F, you should always consider they also may have a right
ventricular.
infarct. And you want to do right ventricular leads. And if they become hypotensive, giving them fluid is the way to first go.
So next question. 54-year-old male in acute respiratory distress, discharged from the hospital 3 days ago after he had stent placement after an MI, uncomplicated course. Exam is significant for mid-systolic murmur radiating to the base with bivascular crackles. Good. So acute mitral regurgitation. And what gives it away is the mid-systolic murmur radiating to the base. And just know like I know we're not usually actually hearing these in the ED, but in terms of board prep, there's a surprisingly large number of questions that just describe the murmur type that like, just give away the answer.
You can't hear if you don't listen.
65-year-old male with hypertension, hyperlipidemia, coronary artery disease, coming in with acute respiratory distress that started 20 minutes before arrival. He is a little hypertensive, tachycardic, respiratory rate of 35. He has severe respiratory distress with bilateral rales, accessory muscle use, tachycardia. Same thing. So you have a high-pitched blowing murmur. High-pitched blowing murmur occurring after the S2 at the left sternal border in the third intercostal space. So this one is diastolic murmur at the left sternal intercostal. Aortic regurgitation. All right, last question. So what medication is most likely responsible? So whenever you have weird EKG changes relating to medication in combination with bradycardia, and digoxin is one of the answers, it's most likely the correct answer. Amlodipine doesn't actually give you changes in heart rate, neither does lisinopril, and apixaban is a blood thinner. So it shouldn't give you any changes in blood pressure or heart rate. And I'll send out the answers. After.
Alina, you'll send out both the questions